Bismillahirrahmanirrahim. The topic of our discussion today is thyroid disease in pregnancy. Okay, and I will also discuss the thyroid dysfunction and reproductive health from the TOG article. Basically, I have made this presentation from different sources like EBM from TOG article and from High Risk Book of Obstetrics and Gynecology, but I have tried to collect the most recent and latest information about thyroid diseases in pregnancy. Okay, so first of all, let us discuss the subfertility and thyroid disorder. This is a very important point, specifically highlighted in the TOG article about thyroid diseases and reproductive health. Okay, so hyperthyroidism, both clinical and subclinical, is thought to be found in approximately 2.3% of women presenting with subfertility. Okay, this number is very important. 2.3% of women with subfertility are suffering from hyperthyroidism, compared with the incidence of 1.5% of women in general population. Okay, hypothyroidism is common, and with the overt hypothyroidism affecting 0.5% of women of reproductive age. This number is also very important from exam point of view. And mild thyroid failure or subclinical hypothyroidism has a prevalence of 2 to 4%. So all these red points in which I have mentioned the percentages, these are very important from exam point of view. Now, autoimmune conditions implicated in subfertility and reproductive health include antiphospholipid antibodies, diabetes mellitus, SLE. Okay, autoimmune thyroid disease is the most common cause of hypothyroidism in the women of reproductive age group. Now, how frequently should thyroid function test be performed in pregnancy? That is after every 4 to 6 weeks during pregnancy. Now, complications of hypothyroidism in pregnancy, it's very important. Viva question as well. And also in the theory, different question might be asked related to this. We should know what are the complications of hypothyroidism in pregnancy, and this table is basically from TOG article. So we have maternal complications like anemia, postpartum hemorrhage, cardiac dysfunction, preeclampsia, placental abruption. Okay, so APC P2, A anemia, postpartum hemorrhage, C cardiac dysfunction, APC, and P2 preeclampsia and placental abruption. In that way you would learn it, you would memorize it. Okay, now neonatal complications include fetal distress in labor, prematurity or low birth weight, congenital malformation, perinatal death, stillbirth, neonatal delay, congenital hypothyroidism if autoimmune. Okay, now this chart is very important because what action we need to take place in pregnancy depending upon the TSH level. This chart is basically from TOG article and we have to memorize it. Okay, so if TSH is equal to or less than 2.5 milliunit per liter, then in that case we don't have to take any sort of action. But if TSH is between 2.6 to 4.5 milliunit per liter, what we have to do, we have to repeat TSH and thyroid autoantibodies. Okay, and when we repeat it, then when we check it and we find that we have low TSH less than or equal to 2.5 milli international unit per liter or negative thyroid autoantibodies, then we don't have to take any action. But if TSH is less than or equal to 2.5 milli unit per liter, but if we have positive thyroid autoantibodies, then in that case we have to monitor TFTs, fetal growth in the event of pregnancy, and we have to inform neonates. Okay, and if TSH is more than 2.5 milliunit per liter, then we have to commence a low dose of thyroxine, repeat TFTs by 6/52 means after 6 weeks, and aim TSH of less than 2.5 milliunit per liter. If thyroid autoantibodies are positive, TFTs, fetal growth in the event of pregnancy. Now coming to the TSH. Okay, TSH, if we checked it in the start and it was more than 4.5 milliunit per liter, What we have to do? We have to check T3, T4 thyroid autoantibodies and commence levothyroxine and titrate the dose. Then, what are the risk factors for thyroid dysfunctions? The risk factors for thyroid dysfunction include history of thyroid dysfunction or thyroid surgery, family history of thyroid disease, goiter, positive thyroid autoantibodies, clinical symptoms or sign of hypothyroidism, diabetes type 1, and history of miscarriage and preterm delivery, other autoimmune disorders, history of subfertility, history of therapeutic head or neck irradiation, and age more than 30 years, previous treatment with amiodarone and previous treatment with lithium, recent exposure to iodinated radiological contrast agents. Now we have certain trimester specific TSH ranges. Okay, if in the first trimester we have TSH checked, we should know that it should be in the range of 0.1 to 2.5. In the second trimester, it should be in the range of 0.2 to 3. In the third trimester, it should be in the range of 0.3 to 3. Okay, now hyperthyroidism occurs in 0.2% of pregnancies, and 60% of pregnant women with hyperemesis gravidarum in early pregnancy experience the transient hyperthyroidism. Graves' disease causes 95% of cases of hyperthyroidism in the pregnancy. Now, what are the main causes of hyperthyroidism? The main causes include autoimmune, Graves' disease, toxic nodular goiter, toxic adenoma, subacute thyroiditis, iodine deficiency, iodine therapy, drug or amiodarone, and lithium. Okay, so we have to remember all these causes. Now, maternal effect of uncontrolled hyperthyroidism. Maternal effects include preeclampsia. We have higher risk. Thyroid storm and thyrotoxic heart failure. Both are an acute and life-threatening conditions in pregnancy caused by an excess of thyroid hormone. Now, what are the clinical features of thyroid storm? Those are fever, tachycardia, cardiac dysrhythmia, and central nervous system dysfunction. Treatment should be carried out in a critical care setting with anti-thyroid medication, steroid, beta blockers, and supportive measures such as temperature control. Now, fetal effects of uncontrolled hyperthyroidism. That include fetal growth restriction, prematurity, stillbirth, fetal or neonatal thyrotoxicosis. Means the neonate of the mothers with a Graves' disease may develop goiter and hyperthyroidism due to transplacental transfer of stimulatory TSH receptor antibodies. Neonatal thyrotoxicosis is treated with anti-thyroid hormone drugs and beta blockers. It usually subsides within the 6 months, but if untreated, there is a 30% mortality rate. Neonatal hypothyroidism can also occur due to placental transfer of maternal anti-thyroid drug, pituitary thyroid axis suppression from this drug transfer, or rarely from placental transfer of blocking thyroid receptor antibodies. Okay, now management of overt hyperthyroidism in pregnancy. Overt hyperthyroidism in pregnancy management is in 2 lines. Okay, first of all, we may have history prior to conception, patient already diagnosed with hyperthyroidism, and there's another group of patient who has got new diagnosis during pregnancy. So if patient is already a known case of hyperthyroidism, then in that case we have to check TFTs at the initiation of prenatal care, and we have to adjust propylthiouracil, methimazole 50 mg or 100 mg increment respectively. Therapeutic goal would be T4 1.2 to 1.8 microgram per deciliter. Free T4 should be kept at or moderately above the normal reference range. Okay, now coming to the newly diagnosed case of hyperthyroidism. In that case, we have to initiate the anti-thyroid drugs for gestation of presentation. Okay, and propylthiouracil PTU 100 to 150 milligram TDS, methimazole 10 to 20 milligram BD, carbimazole 1.5 35 to 40 milligram daily. Okay, so we have to initiate depending upon the gestational age. If she is in the start of pregnancy in the first trimester, we will go for PTU as it is least teratogenic. Okay, so in that way we will manage. Okay, means if the patient is already diagnosed case, in that way we have to check TFTs and adjust the dose, and we have to increment it. Okay, but if she's already a diagnosed case, if she's new diagnosed case, then we have to start with these doses. Okay, now propylthyroxine and methimazole or carbimazole difference is shown in this table. Okay, propylthyroxine, about this it's written that it blocks thyroid hormone synthesis and reduces the titer of TSH receptor antibodies, whereas the methimazole blocks the thyroid hormone synthesis and reduces the titer of TSH receptor antibodies. And PTU less crosses placenta than carbimazole and methimazole, whereas methimazole and carbimazole cross placenta. Third point is that PTU does not causes fetal anomaly, but is a proven cause of maternal liver damage. Okay, it damages maternal liver, but it rarely causes fetal anomaly. So risk of maternal damage is 1 in 10,000. And about methimazole or carbimazole, it is written that possible rare risk of fetal aplasia cutis, patches of absent skin, if used in first trimester. I will show you the picture of fetal aplasia cutis later on. Now, another difference that there is small chance of maternal neutropenia and agranulocytosis. We have to request FBC if patient presents with a sore throat. Okay, and another point about the same point about methimazole is that there is a small chance of the maternal neutropenia and agranulocytosis in this case as well. So request FBC if the patient presents with sore throat. Another point, PTU is safe in breastfeeding if dose of 150 milligram is taken. Now, carbimazole is safe in breastfeeding if the dose of less than 15 milligram per day is taken. Okay, so 150 milligram for PTU and 15 milligram per day for carbimazole. If we take less than these doses, then both are safe. Okay, another point, the last point, TFTs of the neonates should be checked at birth at regular interval if mother is breastfeeding and taking higher dose of medication. About methimazole, it's written that TFT of the neonates should be checked at birth, regular interval if mother is breastfeeding and taking high dose of the medication. So same point about both. Now coming to the criteria for thyroid storm, hydrotoxicosis, elevated free T3 and free T4 is a prerequisite, and it requires various combination of the following symptoms. Well, first of all, CNS manifestations like restlessness, delirium, psychosis, mental aberration, lethargy, solemnness, and coma. Fever 38 degrees centigrade, 100.4 degree Fahrenheit or greater, tachycardia 130 per minute or higher, CHF, pulmonary edema, raise, cardiogenic shock, and NYHA4, GI hepatic manifestations like nausea, vomiting, diarrhea, total bilirubin 3 milligram per day or more. Now we have to define thyroid storm. Thyrotoxicosis, elevated free T3 and free T4 plus at least one CNS manifestation plus one or more other symptoms like fever, tachycardia, CHF, GI hepatic, or a combination of at least 3 features among fever, GI hepatic, CHF, or congenital heart failure or tachycardia. Suggested thyroid storm, a combination of at least 2 features among tachycardia, congenital heart failure, and GI hepatic fever, or a patient with a history of thyroid disease, presence of the goiter, and exophthalmos who meet the criteria for TS1, but TFTs are not available. Now, side effects of carbimazole. Okay, this is what I was talking. So carbimazole and methimazole are associated with congenital condition aplasia cutis congenita in the fetus. This rare, reversible and benign condition is characterized by skin defect mostly on the scalp along the midline. The skin defect can also be seen in symmetrical distribution peripherally on trunk, face, and limbs. Now, though propylthyroxine is preferred agent, carbimazole and methimazole are not contraindicated in pregnancy. It needs to be changed. The woman stable on these medication pre-pregnancy, as this complication is very rare. Incidence of overt hypothyroidism in pregnancy is 0.5%. Hypothyroidism causes include primary hypothyroidism like autoimmune disease, atrophic hypothyroiditis, Hashimoto thyroiditis. Iatrogenic causes include radioiodine therapy, thyroidectomy, antithyroid drug. Transient conditions include subacute decoherent thyroiditis, postpartum thyroiditis, and iodine deficiency. Secondary hypothyroidism causes include pituitary failure and pituitary tumor, and tertiary hypothyroidism includes the hypothalamic failure. Now we have effect of pregnancy on hypothyroidism and effect of hypothyroidism in pregnancy. Pregnancy itself has no effect on hypothyroidism. In 25% of the cases require increase in thyroxine dose in pregnancy and only response to abnormal TFT interpreted with the reference to the normal pregnancy. Routine increase is not recommended. Now, effect of hypothyroidism in pregnancy. Maternal effects include increased risk of miscarriage and maternal anemia. Fetal effects includes the risk of the fetal loss, low birth weight in infant, not IUGR. Neonatal effect includes neurodevelopmental delay in offspring, reduced intelligence quotients, severe maternal iodine deficiency, neurological cretinism, deafness, spasmodic motor disorder, hypothyroidism. Now coming to the management of overt and subclinical hypothyroidism. Overt hypothyroidism occurs in 2 to 10% of the cases in which we have elevated TSH using pregnancy-specific ranges for each trimester in conjunction with a decrease in free T4 concentration. And patients presents with the signs and symptoms of hypothyroidism, and we have increased rate of miscarriage, fetal anemia, and low birth weight, and treatment recommended with thyroxine. If we have subclinical hypothyroidism, incidence is 2 to 5%, and an elevated TSH with a normal free T4 concentration, no specific signs and symptoms, and may increase the risk of placental abruption and preterm labor. Treatment is with the thyroxine that may improve the outcome. Now, how to manage a patient with a previously diagnosed overt or subclinical hypothyroidism. In patients with a previously diagnosed overt or subclinical hypothyroidism taking levothyroxine before pregnancy, the dose should be increased initially by 25 microgram daily once the pregnancy is confirmed to compensate for increased T4 demand of the pregnancy. Thyroxine should be commenced and adjusted to increments of 25 to 50 microgram. In a newly diagnosed case of hypothyroidism, start with a dose of 2 microgram per kg per day. Now, thyroid function should be monitored every 4 to 6 weeks, and further increase in levothyroxine dose may be required to maintain the optimal TSH of 0.5 to 2.5 milliunits per liter and free T4 of 1.4 to 1.8 microgram per deciliter. How to manage women with a euthyroid? How to manage euthyroid women with autoimmune thyroid disease? These women should have thyroid function checked every 4 weeks in early pregnancy and at least once between 26 and 32 weeks. Can we prescribe radioactive iodine in pregnancy? No, it should be avoided, and pregnancy should be avoided for 6 months after stopping it. What is the best time for thyroid surgery? That is the second trimester. What happens to thyroid function test after delivery? Following delivery, thyroid function quickly returns to the pre-pregnancy level, so levothyroxine therapy can therefore be changed to pre-pregnancy doses, but thyroid functions should be checked at 6 to 8 weeks postpartum. Risk of the postpartum thyroiditis is maximum at 3 to 4 months postpartum. Now MCQ. A 25-year-old woman known to have hyperthyroidism is going for radioactive iodine therapy. She has been trying to conceive for the last 6 months. How long she should avoid pregnancy after this treatment? We have different options and the answer is 6 months. Okay, thank you so much for your kind listening. Allah Hafiz.